have all these interesting things to say. So I hope you find them interesting tonight, but actually, to be serious, I hope you find them valuable. It's great to be with you tonight. Thank you all for zooming in, and for listening to me talk about this book that's come out about a year and a half ago called Patient Safety Ethics. And what I'm going to do tonight is talk to you about, just some of the bullet points of this book. I hope I can get done in about 20 minutes because I sure want to hear what you have to say. I sure want your feedback. But what this book attempts to do is talk about these 4 categories. What I was looking for is, what are the ethical principles that would moderate or govern patient safety, or that would inform patient safety? Some of you might have heard over the years that when we talk about bioethics or medical ethics, we very often revert to 4 principles that Tom Beecham and Jim Childress wrote about, actually beginning in 1978. And those principles are autonomy, non-maleficence, beneficence, and justice. And those are 4 principles that inform bioethical dilemmas. They're questions about patients' rights and harms and benefits and justice and fairness and all that kind of stuff. So what I was doing was thinking about, well, are there like 3-4 principles that would apply to patient safety? So I came up with these 4: vigilance, mindfulness, compliance, and humility. And I'll explain what each of them means as we proceed. And like I said, I'm going to try to finish this talk by 7:30. I will watch the time fairly closely to make sure that we're on course. All right, so why do we have disasters? Why do we have catastrophes? Thank goodness, although errors are relatively frequent, it's usually the case, as you all know, that errors are very frequently snuffed out. They're intercepted before they reach the patient, or they reach the patient and thank God they don't do any harm. So when we have a disaster, though, I mean a serious error-caused harm, what you're always looking at are, the Jim Reason Swiss cheese model that talks about very dynamic environments of healthcare, that healthcare providers have to deal with these multiple sources of concurrent information, not all of them being accurate, varying accuracies. They very frequently are shooting from the hip, unlike me, who can, mull and contemplate a bioethical problem for hours. A lot of healthcare providers, a lot of doctors have maximum of 15 seconds to make a decision. These are also very high stress environments, complex human to machine interfaces. You have multiple people on a unit with varying levels of competence. So, you put all of this together. So you have an imperfect human being who is interfacing with a complex, oftentimes imperfect environment. And, it's not a question of whether disasters are going to occur. The question is simply, when are they going to happen? And James Reason's Swiss cheese model, I think, was just an incredible game changer in all of this. The idea that disasters are the result of multiple people making multiple mistakes that somehow penetrate the defenses of an institution. I mean, that was new and that was amazing. And what's also amazing is it's not just in healthcare that this Swiss cheese model is applicable. It's in all kinds of dynamic industries, whether we're talking about Exxon Valdez, whether we're talking about Chernobyl, whether we're talking about the Union Carbide disaster in India. It's always the same phenomenon. You always see the Swiss cheese model work. And Eileen said something to me that was very interesting. She said, what we're trying to do at Pulse and with our advocacy network is have advocates serve as yet another slice of that Swiss cheese, so that, again, we're adding another layer of defense to the system such that that error, which is inevitable, because we're imperfect human beings working in imperfect systems, such that that error is never going to reach the patient. It's going to be intercepted and snuffed out. So one of my goals tonight is to think about how these four notions that I have, vigilance, noncompliance, mindfulness, and humility, might apply. Let's think about that. How they might apply to advocates being vigilant, to advocates being mindful, to advocates being compliant, to advocates being humble. So there they are. Okay, so I also do a lot of medical malpractice consulting. I have consulted both for the defense, but usually maybe 75% of the time, I am called by plaintiff lawyers, the plaintiff bar, to be their expert witness. I've consulted on dozens and dozens of cases. I've been deposed a dozen times. And when I get involved in the case, I read and read and read and read. So I read the depositions of both sides, the plaintiff side, their expert witnesses. I read the depositions of the defense. And consequently, you get a much more elaborate picture of what went on that precipitated that is accounts for this particular med-mal case. And by the way, you also get the justifications and the rationalizations and the explanations of the healthcare providers as to why this went on. So I used about a dozen cases to maybe illustrate these lessons of vigilance, mindfulness, compliance, and humility in my book. So I'm going to talk to you about a couple of these cases over the next 15 minutes or so. So what do I mean by vigilance? What I mean by vigilance is a healthcare professional, or a patient advocate for that matter, monitoring the external environment, the environment of people, the environment of technology, the environments of communication for risks and for threats. So to give you an example of what I'm talking about here, I've consulted on about 4 or 5 cases. As a matter of fact, I have one right now on rapes in healthcare facilities and especially in psychiatric units. These are sexual attacks. The Joint Commission would understand them, would use the word rape. Usually they are patient on patient, and in, I believe, 94% of cases, it's male on female. In a lesser number of cases, it might be a healthcare worker on a patient. And so I studied how the sexual attacks happen in these healthcare facilities, and it was astonishing how uniform the conditions are that enable these attacks to occur. And I'm telling you this because this is a good example of a lack of vigilance in these facilities. So one of the challenges that operators of, let's say, psychiatric units are confronted with is, should we allow males and females to commingle on the same unit? If you forbid that, and some units do, by the way, you have substantially reduced the likelihood of a sexual attack. If you allow it, and I believe most of them do, psychiatry says we have to normalize these treatment environments as much as possible, then, you're inviting at least a problem. The likelihood of a sexual attack goes up when you mix males with females. The astonishing thing that I learned, though, in reviewing these cases was that, number one, again, we're talking about vigilance here. Number one, it's not at all uncommon for nurses at the nursing unit, at the nursing station in this psychiatric unit, to have blind spots or poor visualization. In one particular case, it was acknowledged that from the nurse's station, you couldn't see 4 of the rooms on the floor. They were blind spots. So therefore, you couldn't monitor. You couldn't be vigilant as to what was happening because they were out of sight. Virtually all of these units have video monitoring, but when the staff was asked about the video monitoring, oftentimes they didn't even know what it was there for. And by the way, very often, talk about a lack of vigilance, very often that nurse's station was empty. It was uninhabited. Why? Because the nurses and the technicians were out with patients. They were either admitting patients, they were discharging patients, they were taking care of patients. So this central unit here, this central station that's supposed to monitor the safety of the unit was oftentimes, like I say, uninhabited. So an example there of a lack of vigilance that frankly enabled these sexual attacks to occur. So, you know, what are the things that maybe advocates, but as healthcare professionals need to keep in mind with regard to vigilance? And let me tell you right now, something that I feel very strongly about. For non-healthcare professionals or even healthcare professionals to be good advocates for their loved ones, a particular patient, it behooves them to learn everything they can about the care that their loved one is receiving and his or her medical condition. So you need to learn everything about the medications and their dosages and when the patient gets them, and everything about allergies. And you know, the patients, sometimes some patients respond well to certain medications, some they don't. The more you learn about the patient's diagnosis, the patient's prognosis, all of those kinds of things, the better advocate you can be. But I want to draw your attention to this fourth entity here on this slide, to cultivate skills of foreseeability and thorough vigilance. I took that phrase, thorough vigilance, from James. I'm pretty sure it comes from James Reason, and I really like that phrase. We have too many cats living in our house, domesticated cats, but my wife is a cat person, and she also feeds the feral animals outside. And you know that when you look at that kind of twitchy vigilance of these kitties who come up to our deck and eat the food that my wife puts out for them, as soon as we open up a door, they shoot off the deck, right? Because they're feral. But that kind of anxiety, that kind of constantly looking out for what can go wrong here, that is the kind of attitude and mindset that I think is very, very much part of a good patient safety calibration, if you will. So cultivating that feral vigilance is very, very important. And boy, if the hospital or clinic administrator can cultivate a culture of speaking up, because people on a unit know what's going on. They know the people who are doing their work competently and well. They know the people who aren't. They know what's good about the documentation system, what's bad about the documentation system. They know about things that work well with medication delivery and things that don't work well. To the extent that you could get that feedback, boy, that is a big, big plus for quality assurance and quality improvement. The problem, though, is that very, very frequently people feel inhibited in speaking up, and maybe we could talk about that phenomenon later. Vigilance is monitoring the external environment. Mindfulness is monitoring the internal environment. So the healthcare provider who is constantly asking himself, do I have enough information about this patient to make a good decision? Have I been trained to provide this particular intervention? Am I in over my head? If I'm uncertain, what do I do? Do I know the protocol? So mindfulness, like I say, is monitoring your internal milieu in terms of how adequate your skill set is going to be in order to deliver that kind of care. And I must tell you that when I talk to healthcare professionals today, I believe that maybe the biggest challenge that they have is they're running too fast. When they come into their facilities at 7 o'clock or 6:45 in the morning, and they put in their 12-hour shift. It's just nothing but work, 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 work. They barely have time to go to the bathroom. They barely have time to eat. They're multitasking. They're very worried about meeting their productivity targets and all of that. When you put a human being in a very, very stressful, production-oriented, efficiency-insistent environment, I guarantee you, sooner or later, they're going to be overwhelmed. They're not going to be able to function appropriately. So this is a case of a patient who came into hospital, and I think there was a lack of mindfulness here. This patient had a documented history to sulfa drugs. She came in the hospital with her medical records from a previous hospital that had 2 references to her sulfa drug allergy. Somehow the admitting nurse who was taking the admission information failed to record the sulfa allergy. Maybe she was never told. I believe the patient's daughter was giving the admitting nurse the information. The patient's daughter claimed that she did tell the admitting nurse about the sulfa allergy, but maybe she didn't. However, a few hours later, when the patient was having her history and physical taken by a nurse practitioner, the nurse practitioner listed on her H&P paper note that the patient had an allergy to sulfa drugs. The following day, a pulmonologist was called in by the attending to do a pulmonology consult. He noted on his record that the patient had a sulfa allergy, but the great problem in this particular case, the fatal problem, was that these notes attesting to the patient's sulfa allergy were never transferred to the allergy drop-down box. 7 days later, this patient, who was quite ill, by the way, she was 78 years old, she had pulmonary hypertension, she had lots of drug allergies too. The patient's physician comes into her room. I believe she's waiting to be discharged. She's got her suitcase packed, she's waiting for her ride. And he tells her that she's colonizing bacteria in her sputum and urine, and that he's ordered a really good antibiotic for her. And a nurse comes into her room a little while later and gives her a tablet of Bactrim. Bactrim is a sulfa drug. The nurse never asks her if she's allergic to sulfa. The physician at his deposition said, look, and this is kind of interesting. He says, I went into before I ordered the sulfa, the Bactrim, I looked at the drop-down allergy box in her electronic health record. I did not see Bactrim or sulfa listed there. Consequently, I felt it was okay. And he kept saying throughout his deposition, you got to depend on the system. You got to depend on the system. You got to depend on the system. And unfortunately, she got the sulfa drug. She took the Bactrim in less than 2 hours. She began to experience rash and shortness of breath, classic signs of a drug allergy. The following day, she developed signs and symptoms of Stevens-Johnson syndrome. Then the following day, I believe that day she's helicoptered to a teaching hospital, but she dies the following day. Stevens-Johnson's syndrome is absolutely horrible, by the way. Interestingly enough, none of the health professionals admitted negligence or wrongdoing. Everyone said that they were following the standard of care. Of course, the mindfulness thing, whenever I present this, especially to nursing groups, present this case, virtually all of the nurses say when that nurse gave that patient the Bactrim tablet, he, in this particular case, he should have asked her, despite what was on her medical record or was not on her medical record, do you have any allergies to drugs, Mrs. Jones? This is a sulfa drug. Do you have any allergies to sulfa drugs? But the mindfulness component there was, well, it's not on the drop-down box, so therefore it must be okay. The feral vigilance really was not present there. I will tell you that every medical malpractice case I have consulted on, there has been a compliance deviation, a compliance failure. And here are the most common ones. The most common ones are infection control lapses, right? Not washing or sanitizing hands, skipping infection control measures, not checking gloves, failing to check armbands, not performing safety checks. Basically, these are deviations from rules and standards that are there at the hospital. And it is a nail in any healthcare professional's med-mal coffin, when you can point to, when that plaintiff lawyer points to the fact that this is a standard at your hospital, Dr. Schmo, isn't it? Yes. Did you follow it? No. Standards, you have to do them. They're not like guidelines. Guidelines are recommendations or suggestions. Standards are that you have to follow these. Like I said, system operators, though, oftentimes are inhibited from speaking up. You know, Gretchen has been acting kind of strange the last couple of weeks. Oh, I think she might be having a hard time at home. You know, maybe we should call this to somebody's attention. Oh, no, Gretchen's a trooper. She'll get through this. You know, this happens to us all. It's that kind of stuff. And why do I fear speaking up? I fear speaking up because I fear retaliation. I fear speaking up because, you know, I'm going to call someone's attention to something that is not pleasant, and I'm wondering if I'm going to be harmed as a result of that. I have to work with Gretchen every day, for heaven's sakes. Is she going to get mad at me? Is she going to retaliate somehow? But really, if we could somehow figure out how to create an emotional atmosphere whereby feedback is understood as a good and positive thing, this is how you can get better, as opposed to people feeling threatened, as in Eileen wants my job and that's why she's criticizing me. Really, healthcare would be so much better off and frankly, a lot safer. Last of my quartet here is the phenomenon of humility. And this is a woodcut, I believe, of Bernard de Clairvaux, who set humility back 1,000 years. And it was Bernard de Clairvaux that kind of characterized the humble person as someone who is servile, groveling, low self-esteem. Actually, he was creating these characterizations for monks in his monastery. He wanted them to not be uppity. The last thing he wanted was for monks to be uppity. So he preached that the ideal monk is someone who is quiet, who keeps silent unless he's asked to speak, who feels as though he or she is worthless before the eyes of God, all that kind of stuff. Any psychologist would tell you that is terrible. I mean, that breeds a kind of very unhealthy, low self-esteem, and it's just not good. We have today, if you ask contemporary psychologists today, they talk about healthy humility. They talk about people who have an accurate opinion of themselves. By the way, the narcissist is the antithesis of the humble individual, whereas the narcissist only thinks of himself and only understands the world and other human beings as an extension of himself or herself. The humble person does not think very much about themselves. In fact, psychologists even say truly, authentically humble persons are kind of rare. They just don't feel a need to think a great deal about themselves. They're much more interested in helping others. They have a very accurate bead on what they do well, on what they have a kind of moderate skill set doing, and what they're lousy at. And they're not arrogant people either. They seek out feedback so that they might improve. And they also make very good managers, because what they are, they're good at seeing a person's strengths, and they're also good at seeing their weaknesses too. Consequently, good humble managers can place people in an optimal position in the environment. And here are some of the advantages of humility. And I think I've mentioned all of them before. Here's the question, though, and I know that all of you have seen it. Yes, there are humble healthcare professionals out there, but think about our persons who become physicians. Think about that a student and an undergraduate who gets into medical school. It seems to me that the atmosphere, the personality formation, the training of individuals in medical school, I kind of think it really opposes a humble kind of orientation, because you didn't get into medical school by making mistakes. You stop making mistakes in high school. You grow pathologically averse to error. You become compulsive and you loathe error. I'll quickly tell you about a med-mal case that I'm working on now. A woman who was going to take a new job, very high-powered executive person, makes her last visit to a gynecologist. The gynecologist does a pelvic examination of her. And this woman has had a history of precancerous tumors, dysplasias. And the gynecologist decides that she wants to do a really quick colposcopy on this patient, which is basically you apply acetic acid which is a 5% solution of acid. It's like table vinegar. You apply that to the genitalia, and actually you shine a separate or a special light called a colposcope on the genitalia, and any irregular tissue, dysplastic tissue, eccentric tissue will luminesce. It'll light up. The gynecologist calls her nurse assistant, her CNA, not someone who is a licensed nurse, and says, "Bring me some acetic acid." The CNA, though, looks at the room that the gynecologist is in, and she says to herself, "Wait a minute, we never use 5% solution in that room. Whenever we bring acid into that room, it's always for the removal of genital warts. And for that, we use trichloroacetic acid, which is an 80% solution." She never thinks to herself, and talk about a mindfulness error here. She hears the gynecologist ask for acetic acid, the 5% solution. She hears it loud and clear. But she thinks the gynecologist is making an error, that the gynecologist really means trichloroacetic acid, the 80% solution. The CNA gets the 80% solution, brings it into the room, and then, of course, a series of more errors occur. The 80% solution is applied to the woman's genitalia, and, of course, we have a disaster. It is painted on her genitalia, where you generally use that 80% solution with a Q-tip, because, like I say, it's generally used to remove genital warts. So you want to be very specific rather than applying it with a big cotton ball. So I'm telling you this because when the CNA was deposed and the plaintiff lawyer says to her, "So that was an error, wasn't it? I mean, you're bringing in this 80% solution." The CNA would not admit that she made a mistake. The gynecologist said she made a mistake. The office manager said she made a mistake. Anybody in their right mind would say they made a mistake. But it's just another extraordinary example of the healthcare professional who simply cannot admit that he or she has committed error. So something that you've all heard before, we need kinder, humbler, more realistic environments. I've gone 5 minutes over, but I gotta tell you this wonderful James Reason story. This is my last slide. I heard James give a talk in Canada some years ago, and he told this story. He told a story about a cardiovascular surgeon who was doing a surgery with a senior resident. This resident was just about to graduate from his residency program, and the attending surgeon was allowing the senior resident to do virtually all of this operation. And in the midst of it, the cardiovascular resident nicks an artery. The blood shoots up in the air, and the resident just freezes. He's horrified by what he did. The attending steps in and he begins to repair the nick. And he says to the resident, he says, "You know, in a way, I'm glad you did this because I can show you how to fix it." And I thought that that was just so splendid. I've gotten pushback when I've told this story before because it kind of sounds, like we're using the patient as a means to an end, as in, "I'm kind of glad you did this. It was a horrible thing that happened." But it's just so realistic, and it's just so humble in the face of all the things that can go wrong. And it's just such a wonderful safety mindset. In a way, I'm glad you did this, because I can show you how to respond to it. It's a wonderful story, and it's my fondest hope that that is the kind of emotional environment that exists for our future nurses and physicians. And it's just wonderful, I think. About some conversation.